Good afternoon, everybody. So, look, I know we've all just had our lunch. There's probably a little bit of a lull in feelings and atmosphere. It's also, what are we on, day 10 of COP or something? We've got a really exciting subject for you today. So, we're going to talk a little bit about the role of clinicians in healthcare decarbonisation. I should introduce myself first. I'm Chris Gormley. I'm the Chief Sustainability Officer at NHS England. And we have ambitious plans in the NHS to decarbonise our health system. We launched our strategy, as some may know, back in 2020. It was a world first, I think, in terms of a proper decarbonisation strategy. And it's really ambitious. We've got targets towards 2040 and 2045 that we think are achievable, but they're really, really difficult and they're really ambitious. And if we are going to hit those targets, we're going to have to rely not just on the strategy and a plan and lots of other plans that we've made since then, and we're going to have to really rely on our 1.4 million staff. We're going to have to rely on the clinicians who really drive change and are really the voice of healthcare and can make a difference. As part of that, in 2021, we launched a clinical fellowship scheme. That scheme is now in its fourth cohort. It draws people from multi-professions from across the NHS, whether it's dentists, pharmacists, nurses, midwives. We bring in the people who are really delivering care, and we give them we try to give them a real understanding of what embedding net zero means in the NHS and how you deliver net zero care and how you assure against it. And it's really about building capacity, and we've had such a wonderful experience so far. And we thought we were pretty good at this, and we thought, well, yeah, we're doing this alone. But actually, it turns out there are other people who are doing this equally, sometimes better than us, and actually people who are starting to do it. And we see this as a growing initiative around the world, and a really popular initiative which clinicians want to embrace. So we have three panelists here, so I'm actually going to ask them to introduce themselves and probably just say a little bit about their role and thoughts before we go into a sort of broader discussion. I might actually go to Charlotte first. Charlotte McArdle is our Deputy Chief Nurse in England. Just to give a little bit of a perspective of what it means to clinicians to have this in their portfolio, and also you've benefited from some of our clinical fellows, and what changes they've really driven.
Okay, thank you, Chris. Good afternoon, everyone. It's really nice to be here today to talk about our work at NHS England in relation to sustainable healthcare. And I took up my post 3 years ago, and I was asked to be the lead for nursing, national lead for sustainability. And I said yes, of course. I'm a global nurse. I have an interest in global nursing. I certainly do that. And then I looked around, and there wasn't anybody else except me. And it was one of 3 or 4 big portfolios that I was holding at the time. So Nick, who was our Chief Sustainability Officer at the time, we had a chat, and he very kindly was able to support me with some resources to have one post in place. And then we were able to develop some clinical fellows for nursing. And we've had 5 fellows through the programme in the last few years, and they are all punching way above their weight, I have to say. And each of them have gone on to do fantastic things, and they're all leading work around planetary health, sustainability and climate change on the back of having completed the fellow scheme. But I suppose we had 4 things in mind. Nursing, as you will know, is the largest profession. When we talk about our 1.4 million workforce, nurses makes up 600,000 of that. And it's a big group and an opportunity really to focus in on maximising its potential, and that's what we wanted to do. We wanted to maximise the nursing voice and our leadership in this area in order to get to the net zero targets and to focus on planetary health. We wanted to expand our scope of influence in advocating for people with health inequalities. Nursing has a key role in that to play, and we wanted to grow and nurture our own capacity and capability to really help people focus on quality improvement, because I believe there's a link between quality improvement and lowering our carbon footprint. I don't think those two things are at odds at all. And finally, to amplify our impact, to start talk about what was good, what we could achieve, and what we were learning as part of this process. So each of the 5 fellows have taken on a very particular role in some of those. We have developed 4 exemplar programmes which are all nurse-led, and they focus on a range of issues. The first being lower leg wound care. So we've had an exemplar programme leading on lower wound care, which has shown to reduce our carbon usage by 10.5 kilograms just in the exemplar site. And we know that if we scale that up nationally, we could save £4.5 million by providing better care, better experience, lower carbon, and better staff satisfaction. We also have taken on the infection prevention and control programme, and Imogen, who's here with me today, is one of our clinical fellows, and she has been leading on that IPC programme, and she's been working on sustainable models for IPC, including gloves off. So during COVID, everybody was wearing gloves for everything, and from a nursing perspective, it's really important because it's removing the therapeutic touch, the hand touch between the nurse and their patient. So we really wanted to focus on reducing the usage of gloves, lowering carbon, improving the experience, etc. And Imogen has been leading that work. That has also shown a reduction in carbon and a huge saving to the organisation. So we know that if we can nationalise that as an approach, there are huge opportunities to reduce plastic, carbon, and improve and cost reduction. In maternity, we've been looking specifically at high blood pressure clinics led by midwives, and they've moved from face-to-face clinics to virtual, and a huge opportunity to saving over 300 clinical hours in time. So a number of programmes that we have taken forward. The 4th is around incontinence, massive problem in terms of continence products and the fact that they take 500 years to decompose. They're affecting our water. We are then re-ingesting that from our water supply into our bodies. So we have to find better ways of doing that. We're always going to need incontinence products, but maybe we can find more sustainable ones, and maybe we can go more upstream and prevent incontinence in the first place. So these are some of the work programmes that we're taking forward nationally that we are seeing results from, and that has been led mainly by our 5 clinical fellows. So I see huge opportunity in this for nursing as the biggest profession to engage in this conversation.
Thank you, Charlotte. So hopefully that really, really underlines the impact that we can have through this programme. I might come to you next, Jay, if I can. Maybe you could just say a little bit about who you are, what your programme entails. And I think what we're really here today is to talk about really launching a closer partnership between our schemes. So it'd be good to think about how we actually differ, but also what we can learn from each other.
Yeah, thanks, Chris. So, Jay Lemry, I'm an emergency physician. I'm at the University of Colorado School of Medicine. And our program there, the Climate and Health program, has a few flagship education programs. The first is undergraduate medical education, which are med students. So we have put together a curriculum that is meant to be replicable and very easy to share with others, to think about how do we, in the 4 years in the United States that our students are in med school, how do they learn basic principles when they learn physiology about climate and health. The second is a graduate medical education fellowship. It's a climate and health science policy fellowship. I'm proud to say that John Balbus was one of our architects, so he helped to put this together in 2018. It was the first in the nation. We had 1 emergency physician per year, and then when COVID hit, we reimagined everything. Now we have 5 physicians from all different disciplines, so palliative care, pediatrics, neurosurgery, neurology, and they bring all this perspective from their different medical backgrounds. Each of our fellows has a federal government, United States federal government preceptorship. So one of them is at Health and Human Services with John Balbus, the CDC, FEMA, as well as 5 preceptorships in a nonprofit. Healthcare Without Harm is one of them, for instance. Why are we doing this? This is really meant to give them real policy experience to build credible, knowledgeable, effective leaders, clinical leaders. Then I would be getting hammered by physicians and nurses saying, well, what do you have for us? I can't do your fellowship. I have a busy practice. I've been out 10 years, and we need an educational opportunity as well. And so we scaled up what we call the Diploma in Climate Medicine. It's a non-matriculating diploma, very much in the vein of the Diploma of Tropical Medicine and Hygiene, which the London School offers. It's 300 hours. It's a heavyweight credential, and it's meant to give clinicians a 360, getting into different domains, disaster response, energy policy. So clinicians can be facile in the many different domains that climate change and really be at the table advocating for smart policy and sparring, if you will, with CEOs and policymakers and elected officials who maybe need to be educated and reminded how important health is. And so they have fluency beyond just traditional health domains. So I'll stop there. That's kind of our education program to date.
Thanks, Jay. I'm going to turn to Nick next. For those who know him, you may want to just pull your earphones a little bit away from your ears at this point. But Nick, please introduce yourself.
Introduce myself and... Okay, hi everybody. I'm Nick. I am Australian, everyone can obviously hear. I was once British, I was expelled. I went back, I was expelled again. I'm now down in Singapore at the Centre of Sustainable Medicine, there in the National University of Singapore. Just to take a step or two back, Singapore's right in the heart of Asia. And I think if you go and look around this field over the last 10, 15, 20, 30 years, the field is sort of health, climate change, healthcare, decarbonisation, it has had a centre of gravity somewhere in the Atlantic. Honestly, somewhere between the United States and the United Kingdom. Asia has a population of about 4 billion people and has the vast, vast majority of the world's future carbon. It's so important that that centre of gravity starts to shift. It's so important that each country starts to set up its own training programs. And so we were pretty excited just yesterday to launch a new master's program at the National University of Singapore and a new executive fellowship as well for senior leaders who need that sort of bespoke carbon analytics, leadership, change management training as well. Honestly, for anyone that's interested anywhere around the world, but pretty excited to be training future leaders in healthcare decarbonisation across the region. That centre of gravity shift is important, but as it happens, God, we've got a lot to learn from the people that have been working on this, the countries that have been working on this for a very, very long time. And I think that's probably why we're particularly excited to be here with the United States and with the NHS in the United Kingdom.
Thanks, Nick. Nick, I might come back to you. So we're here at COP. It's actually a touch day in another tent that feels there's been a health day and there was a big health day at Dubai last time. What role do you think healthcare has in the decarbonisation agenda, and how do you feel it's going this year at COP?
Oh, look, the role is pretty basic, isn't it? Right? Either healthcare is responsible for the 5, 6, 7% of emissions that it is sort of putting out there every single day, and it has to reduce those emissions. It also has to act as a sector. It has to act as advocates out for decarbonisation, for climate action, the whole way across the economy. Those two things, tackle the emissions within your system, run the adaptation within your system, and advocate for change out across the rest of the world. That's our job as healthcare professionals here. It's not that complex. There is something important, though, about what we're talking about around training clinicians and building up that sort of fellowship scheme on the first of these. There's two things, I think, about healthcare systems that make that sector a little bit different to a lot of what else is going on in the world. And this may be a little bit apocryphal, but I reckon the people in the transport sector and in the power generation sector have kind of got it easy. I reckon their solution spaces and intervention choices are actually quite straightforward. In healthcare, the work that a GP does is different in every possible way to the work that an intensive care nurse does, to the work that a community occupational therapist does. We aren't one homogenous building doing one thing. We are doing thousands of different things. And so that means that we need thousands of different solutions, and it also means that we need thousands of different specialists and individuals leading those solutions. if you try and run healthcare decarbonisation from a centralised command and control structure, I promise you, you will fail. And you'll fail for that reason, and the other reason you will fail is go and talk to anyone that has been the chief executive of a hospital or a healthcare system and ask them if they feel like they were in charge of the healthcare system or if they felt like the physiotherapists and the nurses and the doctors were in charge. These healthcare systems are effectively organizations of thousands of little chief executives running around providing best available patient care, but they are the people pulling the levers that result in the carbon that is coming out. And so it's for those two reasons, I think, that a lot of this stuff matters. What I'm most excited about at this COP, honestly, has very little to do with what is happening in the negotiations, has very little to do with what is happening in the plenary discussion. What I'm most excited about is the stuff we saw yesterday at Health Day and the stuff we're seeing today at Attach, is that of those thousands and thousands of little chief executives running around hospitals, running around healthcare systems around the world, 10 years ago, they would come to COP to report the things that they hoped to do, to talk about the things that they one day aspired to be able to achieve, and how if we could get our advocacy right, finally we could amass enough power to do a thing. What I've heard over the last 48 hours is those thousands of little chief executives, clinicians running around the world, actually reporting on things that they have done and counting the cost savings, counting the benefits to their patients, and counting the emissions reductions.
Thanks, Nick. And just thinking a little bit about balance as well, maybe I could ask you, Charlotte. So what do you think the opportunities and challenges are in sort of making the play between patient improvements in patient care and quality and actually decarbonisation? Do you see it as a trade-off, or do you see it as the two sides of the same coin?
I definitely don't see it as a trade-off. I was quite surprised to hear so much conversation about the risk to quality if we start to focus on decarbonisation, because I think what I've started to show in the examples that I've used is that actually isn't the experience. And I think that if we focus our attention on actually transforming our health systems to meet the needs of our populations, which are changing all over the world, plus all our health systems are under financial pressure, all our health systems are lacking significant growth in their workforce. We're struggling to meet demand, so we have to change how we do things. And in doing that, in doing the right thing for the right person in the right place at the right time by the right practitioner, we will get the results that show we can deliver better care, better patient experience. Our staff feel like they've done a good job. They go home feeling they've done a good job. And we'll see that those pathway redesigns are creating the opportunity to lower carbon. I went on a visit to a hospital in London to an endoscopy unit, and the lead nurse there was telling me about they have this focus now on sustainable healthcare, and so they made a decision to do their pre-assessment triage, which they used to bring the patient to the facility to do that. And overnight they changed that to telephone triage, and immediately they saved 17,000 patient journeys to the hospital. And I said to them, well, what does that mean in carbon? And they said, well, we haven't worked it out yet. But I said, that's great, because you've done the right thing. You're using your staff time better. The patient doesn't have to travel. It's taken them less time. And you're reducing the carbon. You're more efficient. So I think for me, it's about instilling the tools and the skills to do quality improvement and to use sustainable QI as a framework to do this and focus on the triple bottom line.
Can I just comment quickly? There's something, Charlotte, that you just said there, where I think sometimes we do a good job of convincing ourselves that individuals can't do anything in the response to climate change, and I kind of get that feeling. I sometimes feel that way when I'm thinking about the actions I personally take. In a professional setting, in a healthcare system, you just said that they had immediately overnight prevented 17,000 journeys, and there's something interesting that happens at the scale of a healthcare system, 10% of a national economy. Anything a healthcare system does, that number is multiplied by thousands, multiplied by hundreds of thousands. And so it ends up pretty quickly not being one individual's action. It ends up multiplying and exploding, hey?
And I mean, just one other quick example, Imogen's work that she led on cannulation. So in one ED department, she asked the clinical team, you'll understand this from your background, to think about, before they cannulate a patient, does the patient actually need to be cannulated? because in an emergency department it just happens. It's just in case you need it. And in doing that, in the one emergency department in England, 19,000 tonnes of carbon or kilograms of carbon, and 25% reduction. Better patient experience, no pain, no suffering, less opportunity to introduce infection, saving staff time. Like, what's bad about that? I mean, everybody can sign up to that.
And I'm glad you talked about this, the 17,000, because that question right there is a teachable moment, right? So when the lens was, less work, less problem, you're automatically teaching that it's also carbon, and it's the metric that we're different than a cement company because we have to be thinking about health equity and access to care. And we know that these are all interrelated, right? And so that 17,000 virtual visits allows for that, right? That's all part of it too. And I think that's therein why we need a particular idiosyncratic brand of expertise, because the carbon finance industrial complex, we do need those lessons, but we need that third one, which is the patient-centric posture, right? What are the metrics there?
Some great examples there, and I think that lends itself to the benefit of the collaboration we're talking about. I suspect in each one of our health systems, we're all doing something which is either the same, but probably slightly different or slightly better in terms of how we deliver care, and the benefit in terms of our collaboration will help spread some of that messaging. Jay, what other opportunities do you see? Where do you see some of the other opportunities beyond just sharing that kind of sort of gold example of actual decarbonisation? What else do you bring?
Yeah, I mean, I think the thing that we're in a big teaching hospital, so part of our job is to just be chatty and educate. And in the United States, the people are not tracking on any of this. And so there's still so much to learn where you can say, hey, do you really need that? And, if you put a carbon lens on it, people all of a sudden are like, what are you talking about? And then you're like, okay, thanks for asking. Here's what I'm talking about. So there is an opportunity there. And it's not just the learners, it's the old guard attendings. And I hate to say it, in the United States, it's still, not as much as it was a few years ago, it's a politicized issue. So if you bring up climate, people, wait, hang on, immediately shut down. So I do think it's important to have a science and a tight narrative and a rationale that we know. It's cost savings, it's better for patients. Aren't you in the better for patient game? And then if you can kind of do that in a sober manner, under the guise of med ed, right, medical education, in the many different forms that we have the opportunities to do that consistently, that's a great opportunity. So I think it's leveraging that, the opportunity to talk about how does pancreatitis present, or all the things that we normally do, and put it and be able to have that teachable moment. It's not always going to be elegant or obvious, but it's always there. And I think that those are the opportunities, I think, that as we scale up our learners, to tell them this is now part of your toolbox. Doctors and nurses, go forth, find those teachable moments, and patients as well. People say, what do you do to talk about climate change with your patient? And it can be an awkward interaction, right? If they have appendicitis or whatever, you're not going to talk about that. But when a young athlete comes into our Colorado emergency room and they're huffing and puffing, and just like, wow, I never knew I had asthma. For me to be able to say, you don't have asthma, you have reactive airway disease, the air quality is horrible, and let's talk about why, from the wildfires, right? So those are, again, teachable moments and opportunities.
Anybody else wants to talk about opportunity? I think we should talk a little bit about the opportunities of our collaboration and the network. Nick, where do you think we could be? So let's look ahead to Brazil next year, perhaps, or we've worked together for the next year and are combining our strength, our powers. Where do you think we are in 1 year, or maybe beyond, as a clinical fellowship network or bigger?
Well, look, the first COP I attended was a little while ago, and And at that, there were 2, 3, 4 health professionals there in the entire damn conference. Here now, we're here in our hundreds, we're here in our low thousands. So that transition has happened over a very short period of time. What could you see with this fellowship? You absolutely see that this grows beyond 3 countries, because absolutely more than 3 countries are running at this challenge now. The thing that I think is maybe most important is, for anyone that's walked into a hospital that is different to their home hospital, right? You walk into a hospital in the United Kingdom, in Singapore, in Australia, I'm familiar with, in the United States. One thing that kind of strikes you is that they all look really, really, really similar. The way that we run our hospitals and our healthcare systems, the way that we sort of structure, particularly our sort of tertiary facilities, they kind of look identical. And you could kind of think, oh God, I didn't realize I was in a Canadian hospital. So that means that there's a lot of commonality in what those intervention spaces look like and what the actual technical solutions to decarbonizing healthcare within those kinds of healthcare systems look like. Where we differ is that we have different legislative environments, we have different regulatory environments, we have different governance structures, we have different cultures. And so I think almost that similarity and that difference is where the real value of this thing is, because we all can say, well, the solution is quite simple. You don't need piped nitrous anymore in your hospital, regardless of the country you're in. But the way you might go about doing that, well, that's going to change. And so there's a hell of a lot of learning that can happen between these healthcare systems there. You asked what's it going to look like in 1 year, 2 years. Listen, let's go and make sure we can do this properly between these 3 countries. But let's go and find another friend. Let's make sure they're Brazilian. Then let's find a third friend. And is anyone here from Turkey at the moment? Okay, you and I are competing to host the COP after this. But let's make sure that we find 2 more friends, one in Turkey and one in Australia, and properly grow this as we go forward.
Amazing. Jay, go.
I was going to say, we're the group that have stood this up, and we're very fortunate. It's a privilege, and I think what we now need to do is learn from one another. Nick, you and I, the first time I had an aha moment was when you were on stage a couple of years ago at the U.S. Government Center, and the United States Health and Human Services say, the National Health Service is doing this better than anyone. We are going to borrow your approach to metrics. And for the U.S. government to say that was, I thought, wonderful, because it's exactly what they should say. They just don't often say things like that. And I think that's exactly the essence of this, which is here we are. There's not many of us. There is so much to learn, and there is an absolute imperative to scale this up. So part of this is just giving us a reason to talk on a regular basis, have our learners talk, spark on each other's things and say, I notice you're doing this. Have you ever thought about doing it that way? How often does that happen? Fresh eyes. And from that, best practices will emerge. And then, that's why we're here, to say we're coming back in a year, and we know we want to invite others to the table. So whatever this is, it's going to be much better. And we would have had 12 months to think about it. So there'll be much more substance to it to offer our colleagues.
Thanks, both. And I guess part of the value that I see as part of asking, we're in year 4 now. We have 40 alumni fellows, and I sort of see the impact those fellows are having. They go out into the healthcare system. They're doing amazing things. Not only are they becoming leaders in their own right within our national body or within hospital trusts, but they're leading big research programs or big funding programs, and they're really sort of spreading the message. And I see this kind of sort of widening effect of those sort of 40 fellows. I mean, Charlotte, I don't know. I don't know if you can say something about the sort of growing collaboration between clinicians, not just fellows, but how they're spreading that within their trusts or their...
So I think that's the point. With this collaboration, it's the power of the network that sits behind it. So it's for everyone who is a fellow or undergoes education and training and has a role. It's the power that they have then to bring their colleagues with them and to act with agency, I suppose, to do that. And I think, talking about the opportunities in nursing, as a result of having 5 fellows over a few years, we've started to do a lot of enabling work in England around, we've established a nursing network for people involved in sustainability. It's growing. There's over 500 nurses in that. We've established a new hybrid role to allow people some time from their clinical roles, so like an 80-20 split. So they have a day a week to focus on sustainability and making small changes to practice. We've got one of our fellows has just developed a groundbreaking framework for engaging nurses in the circular economy, which we hope to publish very soon. It's the first of its kind. They really are doing amazing work. We had our first ever Nurses Green Week in England this year with 28 events and over 350 participants. And we've engaged at senior level with a lot of senior nurses who are now really interested. But I think if employers are really smart about this, what I notice is a real connection, particularly for new graduate nurses, I'm sure medicine and other professions likewise, to want to do something to protect their environment because they see the damage it's doing. And it really is a retention tool. If employers are smart, they will be using that to recruit staff, encouraging them to be educated and learn about this, and finding ways in which they can make changes to their practice. And I think, we talk about nursing, it's a global profession, the biggest professional group, closest to the point of care, delivers the most care, lives and works usually in their same communities, most trusted by people. Better placed, I think, to advocate for people with health inequalities than we give them credit for. And I really want to see nursing engage in this conversation. And Nick, I'm really taken by your point that there's hundreds or even thousands of clinical professionals here. I might be wrong, probably am wrong, I hope I'm wrong, but I know there are 5 nurses here. We're all here with support from one organisation. And that to me says quite a lot about how nurses are not engaged in this debate, particularly at policy level. So what we need are government chief nurses leading and driving this agenda forward.
Did you tell me something that maybe Charlotte told you that, and I guess the math is quite simple, 600,000 divided by 63. Nurses are 1% of the British population. It's wild.
Absolutely, it's powerful. I think we're going to have to move to questions to the floor in a second. Jay, I don't know if you have any thoughts. I mean, we've talked about some of the wider benefits there. Do you have any thoughts about sort of whether there'd be any role for this network in sort of research or innovation? We know there's a gap in our decarbonisation journey. We know how to do. We know how to do a lot, but there's still that gap. And I know in our plan we have a gap on how we're going to basically find the new solutions in our decarbonisation journey. Do you think this network has a role there?
Yeah, one of the things we are looking at is data sets. We're very hybridized in the United States, so our biggest healthcare data sets are still quite small compared to the population. The NHS is, I don't know about Singapore as much, but I know the NHS is single, right? So you can have big data. And so the age, and the reason I say big data is that we know healthcare systems have had big data since the age of Facebook, right? 15, maybe 20 years. What we haven't been able to do is crunch the big data. And I think healthcare systems are still reluctant to decarbonize because they can't get over that hump to really have the data that they would maybe feel comfortable with to know which knobs to turn to get, for finance, carbon, and health equity, right? I think what we now have seen with AI, it's a very formidable tool for looking at huge data sets and finding linkages that humans never could, and to separate signal from noise, and to really so I think if we can look at AI methodologies with large data sets to find out what are different phenotype approaches for hospitals and hospital systems, and do it in a way that this collaboration allows through many different types of data, healthcare systems, that would really allow us to sort of have an aha moment. And the important thing there is once we sort of see how it works with a hospital in Colorado or Singapore or the UK, we can export these methodologies to any healthcare system anywhere, again with some tweaking and understanding what their population looks like and their energy mix, and that could be a grand breakthrough. And so I think that is real value for us to kind of put our heads together. We have the infrastructure, we have the mandate to do it, and if we come back in a year, it probably won't be a year, probably a few years, to say, hey, we've actually think we're onto something, how about you try it out? That'd be very powerful.
Fascinating. Thank you, Jay. Look, I think we have sort of 5 or 10 minutes left of this session. I might turn to the audience now. Hopefully there are questions for our panel. Please raise your hands. So just take a couple at a time. One there and then one here.
Yeah, hi, thanks very much. So I'm the medical doctor myself. I represent now the International Federation of Red Cross, Red Crescent Societies, which is really very close to communities and community health workers and volunteers. So how would you see, because we have nurses in our system working at community level and maybe not any person with a health background. So how would you see them engaged in these initiatives that you described in terms how we hear their voices and how we ensure their awareness and education better, access to the information and, trainings and...
Thank you. So I think the benefit in the roles that we hold at community level are about advocating for change, so engaging with local communities, engaging with civil society, and helping to raise awareness and deliver education. It's not to do, it's to help support and deliver, and then to allow the community to take control of that and work on what's important for them, because in many of our healthcare environments and systems that will be different depending on our background, our culture, our place of being, and our family circumstances. So we can't know all of that. Our job is to educate, raise awareness, and to help support others to take control and manage their own health. And this decarbonisation is a very critical point in that if we are going to meet the SDGs by 2030 for health and well-being, but also the totality of the 17, because I think they're all interconnected and we have to work in partnership to do that.
Can I just add very quickly, the only other thing I would say is not about individuals on the ground, but the ICRC and the centre that Martin leads, honestly is world leading in a lot of this stuff. So I would hope there's actually a lot that we can learn from the ICRC as part of a collaboration as well.
I would also just add that there has to be a metric of success for our programs, right? So when we measure our success, we have to say, what's the diversity of our learners, for instance? How many nurses, social workers, pharmacists, physical therapists, and so forth. And if the answer is that we have not met our mark, then our recruitment strategy for the following cycle has to change, because that's again it's been defined as a metric of success. So unless you're actively fighting for it, the passive, it'll be a passive process, and physicians generally have more resources, and that may be who you attract, unless again you're creating those systems to recruit and reach out and make sure that is actually who you end up bringing into your programs.
Hello, good afternoon. My name is Jalen. I'm actually from Sushi Foundation, but actually professionally I work as a doctor in the UK, in the NHS. So I think one thing I really appreciate getting some input and insight is kind of like, currently the climate post-COVID, everyone's quite burned out, worn out, and then to do extra stuff to help with decarbonisation, it's quite hard to motivate the staff. And not just the staffing issues, also the managerial issues, because I think there are priorities in terms of pushing efficiency. But I think carbonisation plays a big role in terms of pushing efficiency and patient care. What are your suggestions in terms of pushing these kind of things forward, put it in front of the agenda rather than just pure efficiency?
Do you know what clinicians hate? Clinicians hate being told what to do by managers. They absolutely hate it. I hate it. What clinicians love, and that stuff, it tires them out. It gets them exhausted and it feeds into, you're entirely right, 2020 was a rubbish year. 2021 was a rubbish year, okay? What gets clinicians excited and energized is when they are given the autonomy, the capability, the capacity, and the network to run at something themselves. In the NHS, I know there's a number that they talk about a lot, 92%. When you go and poll them, 92% of the NHS's 1.4 million healthcare professionals want to work for an organization that lives up to its own values. We wanted to test if that was unique to the United Kingdom. Everyone sort of always says, oh yeah, but that's the NHS, things are different there. Nonsense. You poll health professionals in Australia, in France, in Canada, in Singapore, you get almost exactly the same answer. In Singapore, where we showed up, where we've been working, the response was it could not be above 40% of clinicians. 88% of clinicians want to work for a healthcare system that is directly tackling climate change. And 82% of them want to have a role in delivering that change themselves. This stuff energizes people like nothing else, I reckon.
No, I agree, and I think we have to change the conversation. So most clinicians I know don't like what we call the P word, productivity. So we need to start talking about value and the added value that this brings, and we need to focus on doing the right thing for the patient, because that's what puts fire in clinicians' belly. So they don't want to be told work harder and faster and be more productive, when honestly, from I know from it's not just unique to nursing, but nurses tell me they do 12-hour shifts. They don't often have time to go to the toilet. It's a treat to take a toilet break. So we can't ask those people to work harder, but what we can do is talk about the difference that they're making and give them the tools and empower them to start to make small changes that make their life as a nurse or a doctor feel a little bit better at the end of the day.
Thanks. My name's Sue Ann Bell. I'm one of the 5 nurses here, and I'm a professor at the University of Michigan, and I'm also a National Institute of Health Climate and Health Scholar for this academic year. We have a problem in the U.S. where healthcare facilities are increasingly owned and acquired by private equity, where profit takes precedence over quality of care. So is there a message in maybe what you're doing at NHS and at University of Colorado about how that we can give to these private equity organizations, many of whom are represented at COP, by the way, about how sustainability and decarbonization can, help their bottom line, given that that's their priority interest?
Thanks for asking. It's clearly the right thing to do. We ought to do it. It's good for patient care, but that may not sway the private equity group. So then it becomes one of how can we use the levers of sticks to say that you have to do this. It's something that you're mandated to do. If you've looked at notes from Secretary Becerra at HHS or Jonathan Perlman at Joint Commission, we know that these regulations are coming just like they are with all hospital accreditations and hospital mandates. California and Oregon already have them at the state level. Michigan, I'm not so sure. The election, maybe you've heard of this, we just had an election in the US, it's kind of been a thing. We don't know where that's going to go, but I would say that this is not going away because climate change is not going away. The imperative to decarbonize is important, and even places like the National Academy of Medicine, it's at the highest level of priority for medical thought leaders. So it's not going away. So then how do we interpret these important actions to mesh with the incentive structure for healthcare system reimbursement? Because even the most profitable hospital, and again, this is the idiosyncratic thing in the United States, needs government money, even if they're private, to stay afloat. So I think therein lies an opportunity. The election changes things, but it's still there. And so how can we incentivize hospitals to do the right thing when they may not otherwise?
Thank you so much for today's session. Apologies I arrived a little late, but I was wondering if you'd be able to comment on what those incentives might look like, a little bit more, any policy levers that you might like to see pulled in countries across the world that could enable this better.
I'll just start. There are armies of people that follow me around when I'm at work seeing patients with a clipboard, making sure that I wash my hands. We have people whose job it is to make sure that emergency departments and wards are safe so patients don't fall. Where I have to take online courses to make sure that I know infection precautions so my patients don't get catheter-associated infections. And the reason is that the United States government, again, I'm speaking from an American perspective, has mandated that if the metrics don't show that our hospital is at a certain threshold, those checks are smaller that the government writes to a healthcare system. So that's a direct way to incentivize that. So my sense is that if we can co-opt those mechanisms, and there's a lot of reasons to suggest that may be coming down the pike. Again, how soon, we don't know with the election just happening. But those that already exists. We have it's not new territory. It's very familiar, and as soon as a hospital leadership understands that they have to figure this out, or their bottom line will change, then they will quickly figure it out. That's the one thing I also just wanted to say, is that this is jobs. It may not be a full-time job, but as healthcare systems need to decarbonize, they're going to need people that understand how to do it, and understand how to do it with a patient-centric posture. And so I think throughout the world, we're going to need to hire people to do it, and they're going to be paid to do it. And they won't get hired unless they have some level of competency. And I think in many ways, this is a demand. We're excited to do it, but we're also responding to what we anticipate will be a demand for qualified workers.
Please.
Can I go first? Just two things. Firstly, in health, and I heard it yesterday, we're delivering first aid now in health as a result of climate change. It is not only the biggest threat to human life, but it will put huge pressure on our health services, and we will not be able to meet demand. We have to take steps now to be able to manage. We have a limited workforce. That's not going to change in the foreseeable future. In fact, it looks like it's some governments are investing in it, some governments are not. They will not be able to manage the demand for health services unless we tackle this problem now, and we're running out of time. And the second thing is, I'm actually at the moment in the processes of designing a quality dashboard for NHS England, and I'm talking about patient experience, staff experience, health outcomes, value, and sustainable healthcare, to include health inequalities. And when we start to measure those things, we can really see where we make the overall impact. And it's the overall impact, I think, that's the most valuable as a group of metrics, so that you can see you're doing the right thing, you're saving money, you're cost effective, and you're saving the planet. Our principle in safety in healthcare is first do no harm. And that applies in sustainable healthcare. We are harming the planet, both as a system that's dealing with the sickness of people because of climate change, and in doing so contributing to the problem. So we have to sort that out. There's no other way around this now.
Thank you so much. I'm Dominika Flisek. I'm a medical student from the International Federation of Medical Students Associations. And as future healthcare professionals, we take action to bridge the gaps in the curriculum in terms of environment and health, including green hospitals and sustainability in healthcare, through advocacy initiatives internationally and nationally in our countries. And my question is, how do you see the way of including climate literacy on a wider scale and making this knowledge more accessible from the perspective of healthcare professionals of teaching hospitals? What are the vital actions that should be taken by the youth to enhance those changes, so when we become healthcare professionals, we can amplify the impact and implement these fresh ideas that were mentioned today? Thank you.
I'll start. Great question. I'll start by saying you have to ask for it. Ask your dean, ask your teachers, your professors, because if you're asking for it, they have an imperative to respond to it. it can be difficult. The medical school curriculum is very crowded. And so I'll just tell you what we did briefly. We couldn't get any room in the curriculum, so we took advantage of our senior year in med school when there's some electives, so there's a little bit of discretion in terms of students get to choose, and we stood up a climate and health elective with the idea that we don't know how many students would sign up for it, but we have to have it. We have always consistently had over 20 students of a class of 120, right? So we knew the demand was there, and slowly we have the students have worn down our dean, our curriculum deans, as have we, and we have slowly gotten it into the longitudinal curriculum. So it's a little bit of a push-pull. I'll just conclude by saying there's no stronger voice than that of the students.
The IFMSA is, of all of the organizations here, of all of my couple of 100,000 health professionals here, the IFMSA is by far the most impressive organization here. Almost everything that I think I've seen in this space, the IFMSA has championed years before it has actually become mainstream. Jay, I think you're entirely right. I think demanding it loudly. The Think Global campaign, the Healthy Planet campaign, one of the spin-offs, the Planetary Health Report Card, that has sent shivers down the spines of deans right the way across the world. So much so that in Singapore, at the National University of Singapore, when we said, we think we need to get on top of this before you start to get a bad rap, mate, the dean turned around and said, absolutely, but I don't want to just stop at that. I want to make sure that we go even further. Can we create a minor in sustainable medicine to attach to our undergraduate medical degree as well? The answer is hell yeah, and the reason is because of the IFMSA.
Just briefly, I think I see in some undergraduate programs this emerging, but it's not, there's a lot of variation in it, and it's not sustainable, it's not in every program. And a backhanded way, which is probably the least likely or desirable option, actually is for the regulator who regulates the control of the programs for healthcare professionals to insist that this goes into programs. And in my own profession in the UK, the Nursing and Midwifery Council are starting to relook at this, and we expect to have a new version of the code which will focus more on planetary and sustainable health. And as a result of that, I think we will see undergraduate curriculums change.
We may have time for one short question, if there is any. No, we're done. Brilliant. Okay, good. I get to finish on time. Look, I think we've had three incredibly impressive panelists today talk about clinical drive, innovation, passion, the things that are really making a difference to our healthcare system. It's the clinical fellowship schemes which are a real bedrock of making that happen. So it's so powerful. I feel really quite excited about what we're all doing individually, but if we are going to partner, if we are going to bring in some friends by next year, what we're going to be able to talk about in a year's time, 2 years' time, and the strength that we'll bring together. So if I could say thank you to the panellists, and if you could all just give them a quick round of applause, we'll finish there. Thank you.